the Veen. This presentation will relate how I have met the ESSA Accredited Exercise Physiology Scope of Practice 2014 during my clinical practicum placement. The scope of practice was developed by ESSA to outline the boundaries of the practice area for an accredited exercise physiologist. It contains 8 points which I will address during this presentation. I've chosen to deal with the last point of the scope of practice first, as it sets the scene for the remainder of the presentation. This point relates to the various levels of healthcare in which exercise physiology services can be provided. I completed my clinical practicum at a private clinic, which is a tertiary healthcare setting. The clinic was called Maximum Results Exercise Physiology and is based in the town of Bunbury, Western Australia. This clinic aimed to provide excellent quality health services to the local people at an affordable price and with flexibility to suit all individuals. Services offered, and which I was involved in during my practicum, included workers' compensation cases, motor vehicle accidents, strength and conditioning for various athletes from the Southwest Academy of Sport, general weight loss and fitness, diabetes management and injury rehab, including rehab after surgery. The clinic also offered a hydrotherapy service which was run at a private hydrotherapy pool and was made available to all clients. The first point of the scope of practice states screening, assessing and applying clinical reasoning to ensure the safety and appropriateness of exercise and physical activity interventions, which includes conducting tests of physiological measures. On the screen you can see an image of the health screen questionnaire which was developed by Maximum Results based on the ACSM's adult pre-screening tool. The health screen questionnaire is used in conjunction with the physiology pre-screening assessment as shown in Artifact 1.2, which is designed to identify individuals with signs or symptoms of underlying disease and all those individuals who may be at high risk of an adverse event during exercise. By identifying and assessing such things as cardiac risk, the exercise physiologist is made aware of factors that may impact on exercise prescription and gives guidance to providing maximum benefit without increasing risk to the client. It also determines basic fitness levels of the client, goals of the client and their level of motivation, and allows the exercise physiologist to identify any functional impairments which need to be addressed in an exercise prescription. During my time at Maximum Results, I completed initial assessments, which consisted of reviewing client-completed health screen questionnaires and conducting physiological assessments with the client. This included discussing why the client had come to see me, family history of health conditions, client's concerns for their health, and discussing what the client goals were. I also conducted basic fitness, range of motion and strength assessments with the client, which would assist me in prescribing safe, effective and individual exercise programs for the client. The second point of the scope of practice relates to movement capacity assessment in various populations, such as elderly or athletic. During my time at Maximum Results, I was involved with the Living Longer, Living Stronger program, which is a group-based exercise program for those aged over 50 years. As part of the initial assessment process, clients underwent a balance assessment, which was stipulated by CODA. Artifact 2.1 shows the balance assessment that was conducted, and as can be seen, there are varying levels. Level 1, each client began at level 1 and progressed until they cannot perform the requirement of a level. Improving balance is important from a falls prevention perspective, and balance disorders can have serious consequences for social function, such as the fear of falling and functional ability. Moreover, the ACSM guidelines stipulate that older adults should engage in strengthening exercise for balance 2 or more days a week, but not 2 days in a row, and daily perform stability exercises such as heel-to-toe walking. Artifact 2.2 is an example of the strength testing protocol that I conducted with clients who participated in the Living Longer, Living Stronger program. The use of a 1 repetition maximum has been well researched and tested, and has been shown to be a reliable and valid measure of an individual's strength capacity. According to the ACSM guidelines, the 1 repetition max is a safe and effective measure in older adults to determine the appropriate intensity for an individual, which is about 85% of their 1 repetition maximum. A study by Bird and Marion showed that the 1 repetition maximum is a useful measure for designing an effective resistance training program. I also conducted functional movement assessments in the athletic population. Maximum Results offered strengthening and conditioning services to athletes who were part of the Southwest Academy of Sport. The artefact I have included here is a copy of an FMA conducted together with the final report written after this assessment. In this case, the athlete was involved with sailing at a competitive level, and his aim was to make the state team at Nationals in January 2016. In this particular FMA, I conducted a range of objective tests, range of motion tests, and strength movement tests, these being chosen because they were applicable to the sport of sailing. The FMA revealed that this athlete needed to increase his core body strength through dynamic exercise, increase his power and strength throughout the body, and increase flexibility in hamstrings, among other things. Research has shown the FM screen to be a reliable assessment of overall functional strength and movement in the athletic population, and it can be used to identify athletes at risk or prone to injury. As such, it allows an exercise physiologist to design and implement effective training focused on improving weakness in the athlete. Research by Schneiders and colleagues has resulted in a set of normative data being available, giving more accurate and meaningful interpretation of the FMA scores. Designing safe and effective exercise interventions is a key aspect of exercise physiology practice. Pre-screening and movement assessment gives the exercise physiologist the necessary information to provide safe and effective exercise intervention. During my time at Maximum Results, I was involved in the process of conducting an initial assessment, designing and implementing an exercise intervention, and progressing the client to enable them to reach their goals. Artefact 3.1 is an example exercise program that I designed for a 65-year-old lady who had been referred by a GP under an EPC care plan. The client has thyrotoxiosis, which is a condition that occurs due to excessive thyroid hormone and induces hypothyroidism. This resulted in her having low muscle tone and low weight. Her program was designed based on the information obtained during her initial consult and from her pre-screening questionnaire so that she could safely and effectively improve her muscle tone and overall body strength, with an aim of improving functional capacity to maintain independency. In order for her program to be safe, I had taken to condition her pre-existing condition of thyrotoxiosis. I limited her aerobic exercise to a 5-minute warm-up as she experienced an irregular heartbeat. Further, the program was made effective by incorporating resistance training, flexibility, and balance exercises as recommended by the ACSM guidelines. Finally, I designed the program specifically for this client, taking into consideration her own goals. Research has shown that women who reported exercise-related personal goals were 4 times more likely to report high exercise activity at baseline than those who did not report exercise-related goals. On this basis, I had my client write down what her exercise-related goals were so that she could refer back to these while completing her program, and it would assist me in designing the most effective program for her. The next point of the scope of practice refers to the provision of health education, advice and support to enhance health and well-being. The artefact I have shown here is a fact sheet which I compiled for a client who had been advised that she was at high risk of developing osteoporosis. She was unsure what osteoporosis was and what this all meant for her, so I designed the fact sheet to help answer her questions. There are a variety of risk factors for osteoporosis such as age, low body weight and low levels of calcium and vitamin D. For this particular client, her risk factors were gender, as women are at greater risk of developing osteoporosis, and family history, as her mother and grandmother also had osteoporosis. Diet is a modifiable risk factor and plays an important role in the acquisition and maintenance of bone mass. A good nutritional status and adequate dietary protein, calcium, vitamin D, fruits and vegetables have a positive influence on bone health. It is now known from various studies that exercise as a single intervention can prevent falls in community dwellers. Exercise has also been shown to have significant benefits for preventing the development or progression of osteoporosis. The study Osteosize, Strong Bones for Life, found that multi-component targeted exercise was effective for improving bone health and muscle strength. Further research has shown that resistance training, muscle strengthening, and improving core stability all help prevent falls risks. Many of the clients I worked with during my practicum were at high risk for developing chronic diseases. Artefact 5.1 is a program for a 47-year-old female who had hypertension which was currently controlled by a high gluten, and who was at risk of developing diabetes. She told me that she has a family history of diabetes on her mother's side, and while she used to exercise and be generally active, as she has aged, her activity levels decreased, and she wants help getting back into an exercise routine. Objective measures of BMI and waist circumference show the client to be classed at level 1 obesity. After the initial consultation with the client, I designed the program as shown. This program incorporates moderate intensity training intervals to promote cardiovascular fitness with a focus on weight loss. It also includes a combination of resistance training, cardio and core work. This was done because current research shows strong support for combining aerobic and resistance training in reducing the risk of type 2 diabetes. Benefits include better glycemic control, improved systolic blood pressure, and a reduction in waist circumference. 2.6 of the scope of practice states that an accredited exercise physiologist can provide clinical exercise prescription for those with existing chronic and complex medical conditions and injuries. During my time at Maximum Results, I was heavily involved with the prescription of exercise for cancer patients, either through the Life Now or Man Plan programs. The artifact I have here is an example of a program for a client recently diagnosed with prostate cancer and who had just commenced androgen deprivation therapy. Current research by Cormier and colleagues has shown that commencement of a supervised exercise program involving aerobic and resistance exercise when initiating ADT significantly reduced treatment toxicity while improving social functioning and mental health. Further, their research has also shown that appropriately designed and supervised 3-month resistance exercise programs can lead to significant improvements in functional ability and lean mass. Based on this, the Man Plan program is designed to incorporate aerobic training and resistance-based exercises and is run for a minimum of 3 months, with most clients electing to continue with the supervised exercise program as they found it to enhance their quality of life and outcomes of treatment. The final point of the scope of practice refers to provision of exercise-based rehabilitation in the acute phase of injury or surgical intervention. During my time at Maximum Results, I was responsible for providing exercise-based rehab to clients who had undergone total knee replacement surgery. In the acute rehab period following a total knee replacement, the focus is on VMO activation, co-contraction of the hamstrings and quads. This is achieved through the use of isometric exercises and active range of motion. The main focus is also to reduce swelling around the joint, which can inhibit recovery process. Research has shown that early rehabilitation and physical therapy exercise after a knee replacement significantly improves pain reduction and functional state and quality of life. Based on the research, I made use of hydrotherapy-based exercise in the acute stage of rehabilitation to promote early range of motion while minimising impact on the joint and thus reducing swelling. Clients were also advised not to push too hard with the exercises and to ice after each session to help reduce swelling around the joint. Isometric exercises such as quad contractions were conducted to promote initial strengthening knee stabilising muscles, and the client was then progressed to a more comprehensive gym program as shown on the right. For example, a client could start off with a TheraBand leg press, which was then progressed to ankle weights or cable weights. Thank you for listening to my presentation, and I have met the AEP scope of practice during my clinical placement. Thank you.